Welcome everyone, good morning. Thanks for joining us on this Saturday morning. This webinar is the second of 3 webinars in a series entitled Mass Incarceration in the Pandemic, hosted by the UCLA Center for Social Medicine. We have a very exciting lineup of speakers that I will tell you more about in just a moment. First, I just wanted to remind you of our third and final webinar that'll be Saturday, June 12th, and is provisionally titled From Toxic Infrastructure to What Infrastructure? We'll dive into current reforms at the LA County level and beyond and explore visions of how to transform the system, including the Board of Supervisors debates around the Alternatives to Incarceration Initiative, Proposition J, and the Gascon reforms. But now for today's exciting session. Incarceration itself, with concomitant overcrowding, inadequate hygiene, and dehumanizing conditions, puts all inmates and staff at increased risk of physical and mental disease. Between 2000 and 2017, the percentage of California's 115,000 prisoners age 50 or older, and thus at risk of aging-related ailments, more than quintupled from 4% to 23%, while 32% of prisoners were reported to have a mental illness. This dismal situation was only intensified by the pandemic. As of April 2021, over 40% of people incarcerated in California prisons have tested positive for COVID-19, and at least 216 people have died from it. Prison healthcare facilities, underfunded and understaffed, are hopelessly inadequate to deal with the ongoing crisis. Yet, only 3,500 people were identified to be reviewed by state courts for early release in 2020, and the California State Appeals Court found in October that some of the most vulnerable prisoners were not included. Some of the questions we will consider today include: how is providing healthcare in a correctional facility ethical? How is not providing care ethical? How do we reconcile the improvement of care with the goal of abolition of incarceration for individuals with mental and physical illnesses? Does correctional care provide opportunities for advocacy behind bars? How can we support clinicians and inmates who want to reform the system from within? Is it possible to maintain accountability in prison healthcare? And what have we learned from the COVID experience? To discuss these questions today, we have a terrific lineup of 4 speakers. We will be posting longer versions of their biographies in the chat, but in brief, our moderator, Professor Terry Kupers, is Professor Emeritus at the Wright Institute, Distinguished Life Fellow of the American Psychiatric Association, and contributing editor of Correctional Mental Health Report. For the past 45 years, he has served as psychiatric expert witness in class action lawsuits about jail and prison conditions, especially solitary confinement, the quality of correctional mental health services, and the harm of sexual abuse behind bars. Dr. Joesph Goldenson is a physician with 33 years of experience in correctional health care. He served as the director and medical director for jail health services of the San Francisco Department of Public Health for 22 years. In 2014, he received the Armin Start Award of Excellence from the Society for Correctional Physicians, which recognizes its recipient as a representative of the highest ideals in correctional medicine. Patricia Ramdun was granted an emergency health release from prison during the COVID-19 pandemic after 24 years of incarceration for a wrongful conviction, and is a beloved mother and grandmother and a member of the California Coalition for Women Prisoners. While in prison, she received treatment for brain, breast, and ovarian cancer and multiple chronic illnesses, and is currently battling a recurrence of ovarian cancer. The Los Angeles District Attorney George Gascon and Governor Gavin Newsom are working on an official pardon for her wrongful conviction that should come any day. And our 4th guest, Peter Chin Hong, is Associate Dean for Regional Campuses and Professor of Medicine, Division of Infectious Diseases at the University of California, San Francisco. During COVID-19, he has been one of the leaders of institutional and community education around the disease. He has been involved in multiple advocacy efforts to improve health and safety in California prisons, including working on the declaration in the Von Steich case, which was upheld by the California Court of Appeals, who agreed that the indifference at the California Department of Corrections and Rehabilitation met the standard of cruel and unusual punishment prohibited by the 8th Amendment of the Constitution. Before turning it over to Terry Kupers, I want to explain to everyone in the audience to please submit your questions via the Zoom Q&A function at the bottom center of your screen. We are eager to enter into discussion with you and have tried to leave ample time for discussion. We will be reviewing all the questions you submit via the Q&A and strive to answer as many as possible. Also, I want to give a special shout out of thanks to the Leo Rangel Endowment for contributing the bulk of the financial support for our COVID and incarceration webinar series. You can find the podcast of these events on our Center for Social Medicine's website at UCLA. Okay, Terry, I'm going to turn it over to you now.
Thank you very much. Good morning, everybody. I'm very happy and honored to be here to engage in this important discussion with esteemed colleagues and with this socially conscious audience. We have certainly learned anew the importance of social medicine during this pandemic. The first thing we have learned is that we don't have an adequate or fair health system in the wider community in the USA, and certainly not in the jails and prisons. You have to factor in the distribution of medical services. Of course, we are at the highest level of technology in medicine and surgery. I am speaking to you wearing 2 cochlear implants, a wonder of science and technology. They gave me my hearing back and my life back. We have heart and liver transplants, even double bone marrow transplants. But what happens when we switch the topic to perinatal mortality? Again, we have wonderful technology. So at our high power medical centers, we can accomplish near miracles and save lives. But then when we look at the distribution of prenatal services, access to care, our record ranks us with very poor developing countries. Meanwhile, Cuba, which is a very poor developing country, has a perinatal mortality rate better than ours by far and comparable to the most sophisticated European nations. They do public health in Cuba. Every pregnant woman is seen regularly by her physician, and thus a very low perinatal mortality rate. In prison, the Coleman case, the Plata case, have unearthed atrociously unacceptable healthcare in the California prisons. The Rutherford v. Pitches class action lawsuit did that in the LA County Jail. There are comparable cases around the country. And then with the COVID pandemic, the inadequacies in medical care were exposed, including large class and racial biases. As a society, we need to invest much more in healthcare. And we need to work very hard to achieve equitable distribution of healthcare. Back in the day, I was active in MCHR, the Medical Committee for Human Rights, where the slogan was, healthcare is a right, not a privilege. The way we say that today is quality healthcare for all, regardless of ability to pay, and we're far from getting there. The truth is, this society has been disinvesting in healthcare for disadvantaged people ever since the late 1970s and the rise of neoliberalism. That's the theory that dictates tax breaks for the super rich, the end of regulations that hamper corporate profits, and drastic cuts to the social welfare safety net, which includes health and mental health services. For now, I'm going to leave the subject of society-wide healthcare and turn to the situation in corrections. The same disinvestment that characterizes society-wide healthcare and safety net funding characterizes healthcare behind bars. Of course, the budgets for corrections departments, as well as sheriff's budgets for the jails, have been growing geometrically for decades. Again, since the mid-70s and the rise of neoliberalism. But we need to look at specific budget items within the overall corrections budget, for example, for mental health care. Adjusting for the geometric growth of the jail and prison population since the 70s, the budgets for medical and mental health care are shamefully low, even worse than the very low expenditures on public health for disadvantaged folks in the community. Behind bars, the individual suffering from schizophrenia, on average, is not likely to receive adequate treatment in jail or prison. Mostly what's available is short-term suicide observation for acute suicide crises, psychotropic medications, and warehousing in a cell. But the person with serious mental illness is almost certain to wind up in solitary confinement, which is well known to exacerbate the serious mental illness. And then the severity of the illness, the disability, and the prognosis become dire. Consider a scenario I testify about frequently. An individual in solitary confinement, segregation, SHU, administrative segregation, restrictive housing, there are many names for it. this person becomes seriously suicidal and makes an attempt that could have cost his life. He is patched up during a hospital or infirmary stay of a few days, and then is sent back to the solitary confinement cell where he had made the serious suicide attempt. He has a follow-up appointment with mental health staff, of course, but that's weeks or a month in the future. This is not adequate and not ethical care. Medical clinicians' duty includes writing a treatment plan covering all steps of treatment and recovery. After the suicidal person spends a brief time being watched closely in a suicide observation cell, it is not acceptable nor ethical for a clinician to send him or her back to a solitary confinement cell. In fact, it's well known that a large majority of suicides in jails and prisons occur among prisoners who are alone in a cell. Or consider the cell front interview. In all of these kinds of solitary confinement units, official and unofficial, there's a problem having the individual transferred from the cell to an office room where the private or confidential interview can occur. And therefore, the medical and mental health staff tend to go see the individual at their cell. They stand in front of the door. The door might be a solid door with a food port, or it might have bars on it. And they talk about whatever the health or mental health problem is. There's a tremendous stigma in jail and prison about having emotional problems, even being so weak as to have a health problem. And all of the individuals in neighboring cells and all the staff passing by can hear these cell front interviews. Therefore, it's totally unacceptable that that happened. And the staff, mental health and health staff, have to insist on having the individual removed to an office or room where there can be some privacy and confidentiality. Issues like returning a suicidal patient to a solitary confinement cell and conducting cell front interviews put the clinician in an untenable ethical dilemma, sometimes referred to as dual loyalty. If she or he demands too loudly that the suicidal individual must not be returned to solitary confinement, or if she or he refuses to do a cell front interview, custody staff will be very unhappy and could make the clinician's life miserable, possibly even very unsafe in the prison. I always encourage medical and mental health professionals working behind bars, and our professional organizations also, to scream loudly about this deadly kind of substandard care and ethical dilemma. Typically, with systems now in place, if the clinician complains forcefully, he or she will be fired or just treated badly by the custody staff. I believe the clinician should lodge a complaint and take it up the medical or mental health chain of command. That is, to the clinical supervisor, then the medical director, et cetera. And then the health administrators have to argue the point with their custody counterparts, the warden or the sheriff or the commissioner. Let's move on to COVID-19. A lot of healthcare providers worked very hard during the pandemic to keep as many people as they could safe and well. The recommendation of just about everyone, including, I should mention, AMEND, a program at University of California at San Francisco, their leadership during this crisis has been extraordinary. And I'm sure you will hear more about their strong recommendations that the population of San Quentin prison must be downsized by half if we're to avoid many more deaths. Just about everybody's recommendation is to downsize the jails and the prisons. Healthcare and mental health care cannot be distributed to the huge overpopulation we have. And some of that happened, but far from enough. Los Angeles jail and Rikers Island both released between a quarter and a third of those incarcerated after the pandemic burst upon us. The worst thing we can do is to consign a large number of prisoners to solitary confinement, even if in the name of quarantine or medical isolation. In fact, there are 5 times as many prisoners in solitary confinement around the country today than there were at the beginning of the pandemic. In many jails and prisons, the entire facility is locked down. So everyone stays in their cells with no visits, little recreation for months or for the entire length of the pandemic. The Washington, D.C. jail is like that. Solitary confinement causes massive psychiatric damage. Again, Amend has provided us with clear distinctions between quarantine or medical isolation on one hand and solitary confinement on the other. For example, they recommend more contact with loved ones during the pandemic to quell anxiety and keep people in touch, rather than the discontinuing of visits, which is what's happened in many facilities. There's a silver light in carceral settings during the pandemic. The need to release a large number of people from correctional facilities has been a boon to the movement toward decarceration. A large number of people have been released so that they can avoid exposure to the coronavirus. This means that the smaller populations left in the jails and prisons has a better chance of receiving adequate medical and psychiatric care. And there's been no threat to public safety as a result of their release. Crime rates have not gone up. If it worked to release a lot of folks from jails and prisons to avoid death by coronavirus, why not release a lot more after the pandemic ends? We need to embark on and foster massive decarceration. Mass incarceration since the 70s has caused immense damage to the health and well-being of all the people who have been arrested and served long prison terms, but also to their families and communities. Prison is just not a good place for one's health. Life expectancy is much foreshortened if one spends time in jail or prison. And recent studies have shown that people who spend time in solitary confinement have a much heightened death rate in the year following release from prison. In Los Angeles, the County Board of Supervisors voted against expansion of the jail population with the building of a mental health jail. They voted down the mental health jail as a replacement for Men's Central when it is demolished. They also set up a group, the Alternatives to Incarceration Work Group, which is working on ways to divert people with serious mental illness, substance abuse problems, and others to community treatment programs. That's where the treatment should occur. And those programs need to be massively enriched in their funding. A lot of activists and families of prisoners espouse abolition. I like the concept a lot. As Ruth Gilmore and Angela Davis say, what if we didn't have prisons and had to think about managing the problems we currently disappear into the prisons in some other way? How would we manage mental illness, racism, substance abuse, immigration, domestic violence, and so forth? It's a very important conversation that involves envisioning a radically better set of social arrangements. But meanwhile, there are a huge number of people behind bars. Caring, competent, and ethical physicians and clinicians need to figure out ways to provide quality health and mental health care in corrections, even while figuring out ways to massively reduce the prison population. The problems of correctional health and mental health programs are not different than the problems that permeate our entire healthcare system. Distribution, access to care is what makes the American healthcare system shamefully substandard in the eyes of the world. People do not have the ability, who do not have the ability to pay medical fees or the cost of comprehensive health insurance, are not able to get the care they and their loved ones need. It's not an accident that it is certain people who suffer the ill effects of inadequate medical and mental health care. People who are low income and disproportionately Blacks and people of color, as the current COVID crisis is proving anew, receive an unacceptably substandard form of health care. But who is overrepresented in our correctional facilities? Poor people, Blacks, and other people of color. The population in jails and prisons today is well over 40% Black, and they only make up 13% of the population. and I should add people suffering from mental illness. Black Lives Matter has achieved an incredible shift in the public social consciousness. Historians have been telling us for 30 years that Jim Crow and contemporary racism grew out of slavery, and they outlined the prisoner lease program and such. But in the public conversation that accompanies the Black Lives Matter movement, that understanding of the deep connection between racism and slavery has entered everyday parlance. And mass incarceration is the link between slavery and contemporary racism. The same people who are damaged the most by the huge and growing gap between rich and poor and by systemic racism are the people who are disappeared into penal facilities. Is it because they are less human? In other words, they are other? Is it that their physical and mental health does not matter to taxpayers and legislators? After all, health and mental health treatment programs are part of the social welfare safety net that neoliberalism is intent on cutting. Are people who are unable to afford quality health care and mental health care less deserving than those who can afford adequate health and mental health care? Thank you. I will now turn the mic over to Dr. Joesph Goldenson, who created many important innovations while directing health services in the San Francisco jails. Joe?
Good morning, and it's my pleasure to be here with you all this morning. It's a very important topic, and I look forward to the discussion that's going to follow each individual presentation and the question and answers from those of you in the audience. This is mass incarceration in the pandemic is a very broad topic, and I have about 15 minutes, so I decided to focus on a few important things I've learned over the course of my over 30 years involvement in correctional medicine. As was mentioned, I worked for the San Francisco Department of Health in the San Francisco County Jail for almost 30 years. And I've also been a medical expert, served as a court monitor in a number of cases, including Plata, which is the case in California that I'm sure most of you are aware of, and also as a plaintiff's expert in individual and class action lawsuits. Defendants often try to discredit me by labeling me a prisoner advocate. And my response to that is that I'm an advocate for quality healthcare within the correctional institutions. The other thing that often happens is even among staff in the prisons, even medical staff, sometimes people are sort of question why, quote, prisoners should receive better care than they and their families are able to access on the outside. And as Terry mentioned, access to care and the standard of care is often substandard for many people, even those with some kind of health insurance. And my response to that is similar to what Terry was saying, is that the issue isn't that people in prison should have less access to care. It's that people in the community need more access and better quality care. I wanted to start by just talking about the different models by which care has been provided in this country in correctional institutions. There's been three main models that I'm aware of. One is, and the most common model, is where the correctional health staff are actual employees of the correctional department, either working for the sheriff if it's a county jail, or Department of Corrections in prisons. And in that situation, the medical staff reports through a custody chain of command. Another model, the one that we had in San Francisco and the one that is in LA now, is where the care is provided through a contract or an agreement with the local health department. And in my experience, this is the most effective model. Staff report through a health-oriented versus a security-oriented mechanism. This allows for somewhat more autonomy among the medical staff than if they actually have a custody supervisor. And, you know, it's easier, I find, to really get across the message that people in jail and prison need to be treated as patients, not as prisoners, by the medical and mental health staff. In addition, I've often found that it's because there's control of the budget by the health department. It's easier to get needed supplies and staff and other resources, although that's definitely an issue everywhere. And while it's somewhat better if the health department's involved, I've seen it being a huge problem even when health departments are involved. The final model which is developed over the last 15 or 20 years, are these private nonprofit companies that will contract with a sheriff's department or a Department of Corrections to provide medical care. And all I can say about that is I've found them to be very lacking, and the mix of healthcare and profit doesn't work in general in society, and it certainly doesn't work in correctional institutions. Who is in prison? As Terry mentioned, a majority of individuals in prison suffer from mental health, substance abuse issues. A large proportion of prisoners are aging. Studies have been done that show that people with a history of incarceration are 10 years older physically than their biological age, so that the number of people in prisons who are considered elderly is skyrocketing, as Terry said, as people are being held for longer and longer periods of time. And it really, given who is in jail and prison, it really points out the need for diversion, for letting people out of jail into community settings where they can receive the mental health care, the substance abuse treatment, and the medical care that they need. In addition to this, I think it's extremely important that for those who remain in prison, that the mental health and medical care meets a community standard, and that substance abuse treatment is available to those who need it. And this would include opiate replacement therapy like methadone and buprenorphine. And over the last 10 or so years, I've been happy to see, although in a very small number of places, but small but significant, that people are starting to expand the treatment for substance abuse into medication-assisted therapy. So why is there mass incarceration? Well, too many people are arrested for crimes that, and imprisoned for crimes that really don't warrant incarceration. And also because people are being sentenced to longer and longer periods of time in confinement, to the point where a lot of people in prison really do not pose any ongoing threat to society and could easily be released. And I think that's one of the major lessons that, you know, COVID has shown us, that when pressed for it, institutions were able to release from 25 to 30% of the people in their prisons. And as Terry was saying, I don't think there's any reason why those numbers couldn't increase even further. I remember on one of my tours of a prison years ago, I saw a woman who was probably 90 years old. She was in a wheelchair. She was on oxygen. She had a personal attendant 24 hours a day, and she was basically confined to her wheelchair. And I said to the person who was touring me around. I said, why is this person still in prison? And the response was, well, you don't know what she did. And I said, well, it really doesn't matter what she did because she's certainly not capable of doing it anymore. So I think there's many people in prison who either don't belong there in the first place or are no longer a threat to society and can easily be released. The conditions of confinement are a huge issue in this country, as Terry was alluding to. Prisons are overcrowded, jails are overcrowded, and this overcrowding directly impacts the ability to provide adequate health care and mental health care. In California, as most of you are probably aware, a 3-judge panel in the Plata case ruled that the overcrowding in the California prison system was the primary contributor to the lack of adequate health care and ordered the state to significantly reduce the population in the prisons because of that. The conditions are unsanitary. The food is often unpalatable and not nutritious. There's lack of fresh air and exercise and poor ventilation. And again, all of these things have clearly been shown to impact people's health. And again, COVID is one of the things that it certainly taught us or highlighted, is that these factors that are really a day-to-day part of incarceration in this country, unfortunately, significantly contributed to the pandemic in the institutions, and that, you know, the jails and prisons population needs to be reduced so people aren't living on top of each other. There needs to be better ventilation. This is especially important after finally CDC, after months, acknowledged that COVID can be spread airborne, and that poor ventilation systems definitely contribute to the spread of the infection. It's not enough to me to say that we have to reduce the prison population, because as again, most of you are aware, the rate of recidivism in this country is extremely high. And in order to address that, when people are released, there needs to be access to ongoing health care, substance abuse treatment, mental health care. People need housing, they need educational opportunities, and they need employment. So without those things being in place, you know, it really is a huge struggle for people to maintain once they are released. There needs to be better, and all those things really need to start inside the institutions, where there are education programs that really help people get ready to be on the outside. There needs to be real significant job training. I know in San Francisco, many years ago, the sheriff applied for and received permission from the state education department that the San Francisco jail became a licensed educational institution, so that people who are taking courses there were able to get high school and college credits for the work they were doing. Programs like that need to be repeated in other places. I agree with the things Terry was saying about abolition, that while the overwhelming number of people in prison really don't need to be there, and the population can be significantly reduced, there are unfortunately some people that do need to be kept away from others. and segregated from the general community because of the risk they pose to the community. And I think what we need to do is really reimagine and reinvent incarceration so it is more humane and civilized, and that there will always, in my opinion, be a need to, as I said, keep certain people separate from others, but it needs to be done in a humane, civilized manner. So working inside an institution as a provider or on the outside as a medical expert, does allow one to work at improving some of the conditions, such as the food, the exercise, to improve the quality of mental health and medical care, to ensure that prisoners are treated in a humane way. But there's really, by working as a provider or medical staff, you're not going to transform the system in that way. Unfortunately, in my experience, up to this point, the only way that has really been successful in fixing conditions in institutions has been through legal action. And hopefully through public movement can force legislatures to institute changes, and taking the model that was developed during COVID for releasing individuals, really focus on a mass reduction in the number of people who are incarcerated. And then finally, just want to briefly discuss the impact of the pandemic. As I've said, the large numbers of prisoners infected with and those who died from COVID highlight many of the problems with our current system of incarceration, including overcrowding, poor sanitation, poor ventilation, and inadequate health care. All of these issues are all too common in correctional facilities, and were critical factors in the spread of the virus. So the pandemic really underscored the need to radically change the way in which facilities are structured and the way in which healthcare is provided. So thank you, and I look forward to the discussion.
Thank you, Joe. That gives us a whole lot of material to talk about, and the conversation is rich. Next, we're going to hear from Patricia Wright Ramdun, who is a hero. She survived many years in prison, and she came out not a bitter person, but rather an advocate for social arrangement change. So Patricia, take it away.
Okay, yes. Okay, mine started at the county jail when I was first arrested, and started my court proceedings. I'll start right at my preliminary and into my trial. And at my trial, I don't remember anything at my trial. I was giving, I call it psych meds. I don't remember my judge. I don't remember anything about my court hearing, because from the county jail, I was given medication after seeing a psych, and they told me that I needed medication because to calm me down. I don't know why I wasn't upset or anything, but by the time I got to the county jail, the Superior Court, I was drowsy. So I couldn't tell you what my judge looked like. I don't remember who was there, and I was told later, but that's what a psychiatrist did to me. I was only told what happened at my court proceedings. They said that I was given psych meds to keep me calm. And I have no recollection of my trial or anything. So when I did get to, I didn't know anything about my conviction. Tell Mr. Kupers I can't see anything. I don't even know anything about my conviction. All I know is that I ended up going to CCWF, and I was told that I was sentenced to an LWOP. I had no idea what it was. It was crazy, and I was taken to see a psychiatrist there, and he gave me meds for about 2 weeks. I walked around like a zombie, and I just said, no, I can't do this. I was told that I need to go and to be taken to a place. And I said, no, I can't do this. I had to stop. And I just stopped taking the medication. I refused the medication, and he told me that after refusing the medication, that I would get in trouble. And I said, I have to take that chance. And from that time on, I refused the medication, and I went on my own. And I found out that I sought help from one sister and found out what happened at my trial, and found out what an LWOP was, and found out that I was sentenced to a life sentence. And it was, I was hysterical because I didn't know what had happened at my trial. And that's when I started getting busy. I found out where the law library was. And I saw that mental health was not my friend, because I saw that other people was getting locked up in mental health, shackled up, and being treated not very good. So I sought the help of a clergyman, and who only told your business through the doors, like the doctor said. And so I sought the help of a rabbi. And that's why I talked to him, and it was private. And that's who I stayed close to. It was the rabbi. Because when you talk to the doctor, like he said, they talk to you through when you talk to the doctor, they open the door and all your business was out in the hallway. The whole hallway, other inmates knew what was going on with you medically, and it just wasn't right. So it was horrible. Time went on, legally blind, couldn't see my way out. And didn't know what to do. Unclean conditions, diagnosed with cancer. And the doctor's telling me you're gonna die. So I didn't know what to do. All I know was to fight and do the best I could. But I know not to go to mental health, because I know that they would shackle you up, put you in a room. So I end up at SNF, which is a skilled nursing facility. Battling cancer, one cancer after another. But I know that I was not going to die in prison. but I was not going to mental health. So I fought cancer, but I watched so many of my friends die because they gave up. And I refused to give up. But mental health was not the way to go. Because all they did was put you in a padded cell. So after battling that cancer, I got my way down to CIW. And remember, I'm legally blind. They have nothing to accommodate legally blind inmates at California prisons. So there's no jobs, nothing to educate you. So I'm just there. So I got down to CIW. Unclean, mice running around your cell, going out to chemo, have to clean your cells with sanitary napkin, your own soap. It's filthy. Shackled, going out to chemo. Then I was diagnosed with COVID, quarantining in a little closet cell. It was horrible. I was literally dying of COVID. I'm just pushing right through it, but I'm cleaning my cell with my own soap. It wasn't good. I was dying not only of COVID, I was dying of loneliness. It was so hard there when you can't have no one there. COVID was killing us, but broken heart and loneliness is killing us even faster. Being abused by younger inmates, cruelty, racism. It's horrible. Us elderly inmates get abused so bad. It's so hard. And having a disability, you can't go to the officers. They just look over you. They don't listen to you. They don't give you cleaning supplies. Half of the time, I didn't even have toilet paper. That's no soap. I did the best I could with just what I had. The nurses was good when I went out. My doctor was good when I got out there. But when I had COVID-19, it was hard on me. Being shackled up, going out to medical. It was hard. When you're going through hearing of people committed suicide, passing down the hallways, looking at someone hanging from this cell, it's not a very good sight. We had one year, we had over 16 women that committed suicide. Sometimes I was afraid to even get in the shower because I was afraid I would see someone hanging. It's not a good sight to see someone's eyes popping out of their head. That's real.
Patricia, this has been very brave of you to share this, and you're sharing this, the pain of being in.
It's so hard. It's hard to forget that. I'm just sorry that your family couldn't come and see you. I was dying.
When they gave you medication, psychiatric medication, and you decided not to take it, you got in
the county jail, I was forced to take it.
A lot of doctors in the audience, and we're very concerned about the doctor-patient relationship. You got in.
I was forced to take it in the county jail.
Disciplined you?
I was forced to take it in the county jail. I don't remember anything in the county jail. In the county jail, they made you take it. I don't remember anything about my trial. I don't remember anything. I couldn't tell you what the judge looked like. They did that to me. I told the public defender that. I said, I don't remember. When I got back to the county jail, then whatever time it was, I said, what happened? People tell me what happened at your trial. I said, I don't remember. I don't remember nothing. After I was convicted, they said, we were there at your trial. I said, I don't remember nothing. I don't remember who was there. I don't remember nothing. They medicated me. I don't remember nothing. And in 2018, they got a machine at CIW. Low vision, where I can read things, and I start reading things. And I couldn't believe the things that were said at my trial. I was appalled with the things that were said, the lies. And so many people recanted all the lies. That's why when I got out, I was dying in prison. I was dying. I don't know how much longer I got to live. I don't know how much longer I got to live. But I just want to just tell the world. And I'm so grateful, Governor Gavin Newsom, to release me and all the people to let them know. I was dying of COVID-19. I'm dying of cancer now. I was wrongly convicted for 24 and a half years. My family told them they could no longer live with the lie. They told on me. They were just mad. They tried to take it back. We got on the Dr. Phil show. They tried to take it back. But I was dying in prison. The conditions are so bad. I left friends in there that are dying. They tried calling me now. They're dying in there. Those women are dying. They're hurting so bad. I just try to save up money. My daughter's trying to put money on my telephone where they can call. Just to say, Breezy, we're dying in here. They call from OPHU. They said, Breezy, we're dying in here. Please help us. Tell somebody. Tell the district attorney. We're dying in here. We're dying in OPHU. We're dying in our cells. Can you help us? Tell her what I can. I'm trying to help. I can't help them all.
You know, I'm going to break in here and move on to our next presenter, but Patricia, you have taught us so much. We all
It's so bad.
fast at these panels. You get a bunch of pictures and we go a mile a minute. We have to give time to the pain and grief which you've brought onto the panel of how absolutely awful it is inside jails and prisons. And that's what the public needs to know. So I really
The day I was released, they wanted my shoes, they wanted the things I had in my locker. I got beat up. I told them to take what they wanted. They came in my cell and beat me up. I said, I don't care. Take what you want. Take what you want. My friend Leslie Van Housen said, she said, Breezy, let him have it. Take it. Just let him take it. Take what you want. Just don't say nothing. I'm not going to say anything. Take what you want. I'm not going to say a word. It socked me in my stomach. I'm not going to say anything. Just take what you want. I was so sore when I got to receive me. But I know that I had loved ones in the parking lot to pick me up. But I was so sore. They hit me in my stomach. They took what they want, but I didn't care because I know I had loved ones. They didn't hit me in my face. They just hit me in my stomach and my back. And they kicked me. But I know I had loved ones to pick me up. And I know that Officer Richie or the officer wasn't going to do anything. I just wanted to get out of there. I just took it. But that wasn't the first time they beat me up. I know that I'm going to be 70 years old. But I know I took that licking. But I know that they beat all of us up like that. And that goes on all the time. Yeah, it goes on all the time. Yeah. But the officers don't do anything.
Patricia, thank you so much for sharing this. And we all need to feel the pain and the grief that accompanies incarceration. You just brought us to that edge. I so much appreciate it. I'm going to move on and ask Peter Chin Hong to step in. And Peter?
I'll make my comments brief, just given the time that we have, just to maximize dialogue. But what I'm going to focus on is 5 things. My name is Peter Chin Hong. I'm a professor of medicine at UCSF, and I was really honored to be involved in part of the UCSF's response to the pandemic, particularly with working with Amend in the prison system in San Quentin in particular. There are 5 things I'm going to talk about, really. The first is the context of San Quentin as an exemplar of what can happen in prisons with pandemics like COVID. The second is what actually happened and why it was really sort of a moral disaster, as well as a medical disaster. The third thing I'll talk about is just from a health professions or medical perspective, why it was ripe for the explosion of cases of COVID that happened amongst the worst in the country. I'll end with some solutions and then talk about some silver linings and where San Quentin is today. So first of all, context, briefly, San Quentin was built in 1852, July 1852. It's California's oldest prison. And if you've been to Alcatraz or have seen it in the pictures or in the movies, that's exactly what San Quentin looks like, except that it's housed with more than 3,300 incarcerated persons, and it's not really meant to either keep that many people in there or use those kinds of facilities in 2021. Prisons are not built to handle pandemics, but San Quentin is really amongst the worst in that regard. So in terms of what happened and why it became a tinderbox for COVID during 2020, as individuals and folks may know in the audience, there was an outbreak in the California Institute for Men in Chino, California, and on April 19th, one of their first incarcerated individuals died. And by then there were about 59 cases there. So in an attempt to sort of protect the individuals with comorbid conditions at Chino, they decided to transfer them to, a less dangerous environment, which the fateful time was transferring them to San Quentin. So about 200 incarcerated men were taken from Chino to San Quentin. At that point, San Quentin had no cases of COVID. They were taken on 3 buses. Some of the men had symptoms. When you look back in retrospective, they weren't tested recently. They were tested as long as a month before for COVID. They was beginning to exhibit symptoms. They came to San Quentin, and I'll discuss some of the conditions that were happening then. And then it just became like a wildfire of COVID. So eventually, at the end of the day, when the dust settled, out of a population of 3,300 men at San Quentin, 2,200 individuals were COVID positive. So that's like almost 70% infection rate or case rate, and 28 deaths. All of these were unnecessary if you think about it, or many of them were unnecessary. And that's almost like approaching herd immunity if you think about what vaccinations are meant to do, but not in the kind of natural experiment we'd like to have. So what happened? Why was it such a big deal from a biological medical perspective? Well, San Quentin, like I mentioned, wasn't built to house people with illness. It wasn't built to handle pandemics. The cells are usually 4 by 9 feet, holding 2 men. You can touch either side of the cell with your arms. The bars are like those that you see in movies. They're open grates for many of the blocks. And the ventilation was very poor. So many of the windows were shut. They weren't open. The fans weren't working. So if you think about it, an oven of COVID, bringing in probably 200 inmates from Chino, who had, many of them had asymptomatic COVID or symptomatic COVID even. You put them in that kind of like pressure cooker with no ventilation, open grates, correctional officers going in and out, staff going in and out. You not only have a wildfire of COVID in the prison, but you also have a wildfire of COVID that spills over into the community. So at the end of the day, Marin County, in which the San Quentin sits, was also being affected. So one of our big points, whenever we went on media or talked about it, was that prison health isn't just about incarcerated individuals. It's also about community health. And I think there's so many, myths and misunderstandings about who is in prison when you talk to people in the community, even the most liberal of people. But by telling them we had to care about it because it affected their health too, I think was helpful in that sense. And of course, at UCSF, we took care of many of the incarcerated individuals with COVID because, of course, the prison doesn't have a hospital. There's a clinic there, and there's no ICU care. And Marin was unable to take care of all of the individuals who needed a more acute care. So they came over to many of the other surrounding counties. So apart from the ventilation, the overcrowding that was talked about, the lack of access to masks or hand sanitizer. I mean, volunteers can even bring hand sanitizer in because it contained alcohol, and it's hard to get soap easily accessible in the prison. So I think all of these things were really setting up the stage for that the natural disaster was going to happen. In terms of possible solutions, I think time is everything. You know, we started working with public defenders a long time ago, relatively speaking, when if something had been done and decarceration of 50% had been achieved, you know, probably hundreds of people wouldn't have gotten ill. I went to San Quentin last week, and there was still a lot of men with chronic symptoms, long haulers. So getting infection is not a walk in the park necessarily. So, you know, at the time when we were doing all of this work with the public defenders, again, the clock kept on ticking and the counter kept on going, and all these people continue to get infection. So that was really unfortunate. So I think in the future, maybe hopefully having a time on and stopping the clock would be great. I think a second point was that loss was heartbreaking. Mental illness is going to be a legacy of this. We really need depopulation of prisons, not only for COVID, which is still raging around the world, but for the next pandemic, which is surely going to come. We all thought it was going to be avian flu. I think what it also taught us is that we're all experts. Anyone can talk about COVID, anyone can be an advocate, and you don't have to be a specialist to do that. And we all need some accountability. I think having San Quentin fined over $300,000 by Cal OSHA was a good symbolic step in really highlighting how they weren't really releasing information to the rest of the community to let people know how bad things were at the time. And I can go on and talk about that. I think the silver linings is that incarcerated people are resilient. And when I went with another clinician last week to San Quentin, we did a Q&A with the men there, particularly around the vaccine hesitant men. And this was all organized by the incarcerated persons themselves from their media unit, which has gotten quite a lot of acclaim recently. There were reporters from them, there were photographers, they handled the cameras, they were making a documentary. They brought men who were vaccine hesitant, and we just answered their myths as a means to, you know, help them understand that the vaccine wasn't rushed or it wasn't live, and some of these other issues. And we talked about structural racism and all that. And at the end, the most powerful moment was when the moderator, who was an incarcerated man himself, asked those who changed their minds about getting a vaccine to stand up. And when several men stood up, it was just, I think, really powerful, even for the men who hadn't stood up. So again, in everything, there is a silver lining and there's resilience. And I'll just end with one quote by Rivers Solomon, who's an American author from The Deep, writing in the novel The Deep. And this speaks to what, you know, Terry, Joe, and particularly Patricia said about loneliness. And in the novel, one of the characters says, "What is belonging, we ask?" She says, "When loneliness ends." So I think unless you end loneliness, you can't have belonging. And I think that's really, I'm really worried about that part of, and that sequelae of COVID. So thanks for your attention.
Thank you very much, Peter. You've really expanded the discussion. Now what we're going to do is have the panelists talk to each other for a little bit. So panelists, if you turn on your video and unmute. Then we're going to hear from Dr. Mariposa McCall, who has had a lot of correctional experience and has been making valuable contributions to the discussion here. And then we're going to open up to questions from the audience. Please, everybody that's in attendance, send in your questions. You can send them in through the Q&A function at the bottom of your screen. And we will try our best to get your questions after we have a little crosstalk with the panelists. Here's a question I want to raise. Joe, you said, just as I'm advocating diversion and treatment in the community for mental health, you're advocating that for health. How do we deal with the security issues? When I talk to staff at medical clinics, hospitals, psychiatric facilities, they say, we're afraid of getting prisoners or previously incarcerated people as patients because we don't have security. How do you answer that? This is a question to all the panel.
Well, you know, one, as I said, I think that most people in prison don't really pose a threat to other people. Even people who have committed violent crimes, lots of times it's sort of for one person, so that it's not, they don't present an ongoing risk of violence. And I think education is very important around that. In San Francisco, we developed a program where people, when they were leaving jail, if they didn't have a medical provider, were referred to one of the community clinics. And I'm really not aware of any problems in terms of security issues that came up from an individual who had been referred from the jail. I think that the issue you're raising is really, you know, underlies a lot of the reason why there's so many people in prison in the first place, that people in the general community, you know, have been frightened through the media and through the powers that be to be afraid of people who are in prison. And this idea of keeping them locked up as long as possible for safety, I think is a myth, and it needs to be debunked. And I think education is the best way to do that. And then once people have the experience, then I think it'll go smoother after that. That as more and more people are starting to be seen in community clinics, you know, people will realize that their fears are not founded.
You know, I totally agree with you. And you're right about the stigma and the stereotype of people who spend time behind bars. I do some trainings at the state mental hospitals, and staff there are very concerned about security. And what I've been advocating for is that clinicians should be trained in security and should also have well-funded security staff and programs available, because a certain amount of mental health treatment does occur in situations that can get out of hand. I mean, you know, arguments can erupt, aggression, that kind of thing. And it's part of mental health practice to be able to deal with those things within a therapeutic context, not turn to the police, which is what we do, for instance, when prisoners are transferred from the state hospitals to the prisons because they're considered too aggressive for the staff. There should be no one who's too aggressive for mental health staff. We need high intensity mental health treatment in settings where security is present. Please, other panelists, feel free to jump in.
I just want to throw in that my experience is that while there are security issues in health settings and in mental health settings, that's not only from people who've been incarcerated, that a lot of times it'll be someone who has no criminal history, but for whatever reason gets pissed off or not happy with the care. So that a lot of the issues that people have raised with me over the years concerning, you know, prisoners and how they complain about this or they do this, you know, the simplest responses for me has always been, well, you see that in the community too. You know, in that sense, I'm not saying there's no risk, but I don't think it's all that much higher than exists just in general.
Other
So I had a question for you, Terry. You spoke a lot about solitary confinement, and I agree with everything you were saying about how awful it is in so many different ways. And I remember I was the court expert monitoring Pelican Bay back in the 90s. And I remember the first time I walked into the facility, I was sort of shocked at myself because I didn't feel horror or any kind of negative feelings about the building. And I know when I walk into jails and other prisons, they're filthy, they're noisy, everything about them is oppressive. And I realized that the thing about Pelican Bay that was so disgusting was it was so sterile.
yes.
And you didn't hear people and you didn't see people. And that's what contributes to the mental illness. And I think, you know, solitary confinement definitely needs to be abolished. And I was very heartened, and I don't know that much about what happened in New York State, but I see that recently they did say that they had to get rid of solitary confinement for more than 14 days, which is in keeping with the UN resolutions. And just in your opinion, is that something that's sort of happening more around the country? Because I was just so shocked when I read that in the newspaper, because it was so different than everything I had heard.
I agree. It's sterile torture. And not only the UN, but the NCCH, the National Commission on Correctional Healthcare, has a standard that we should not be putting anyone with mental illness
I wrote that.
and nobody for more than 14 days.
Right.
Patricia, would you be able to say a few things about solitary confinement?
Had to get that out about.
I think your mute is on. Can you unmute? Yes.
Mine?
Good.
Now we can hear you.
Yes.
Oh, okay. Okay, what did you ask me?
Can you say something about solitary confinement? We're having sort of a medical discussion about it, but you were next to it or in it, in the inside.
Yes, solitary confinement. It's yes. When during my, I would say, yeah, it was driving during my quarantine. Every time I went out, I was quarantined. It was mind-boggling. It was driving me insane. It was I was suffering. I was suffering from broken heart, loneliness. It was just being by myself, just not knowing, the sense of not knowing what's going on, the sense of crying, who was hurting, you know, who's committing suicide, because it was so much of it. At 1 year, I think that was in 2016 or 17, we had 16 suicides in 1 year at CIW. And, you know, it was so many friends of mine, people I know that wasn't just friends, people that I've known come in contact that had committed suicide. And mental health at one time, 2017 and 18. And during the pandemic, only thing they were giving us, we had problems, only thing they were giving us was coloring paper, crayons, when they couldn't come in. 2019, that's all they were giving us was things to color. They come to the door and pass us coloring paper, talking to us through the door. We were unable to do groups. And that's all they were giving us. It's just colors.
Hmm.
And when you needed someone to talk to, we weren't able to talk to our families. the phone calls was limited. And solitary confinement is not good when you're unable to communicate with not even your neighbor.
Thank you. And, you know, it's far different. I go in and look at solitary confinement units all the time, and I criticize them and talk about the damage, but to live in it and with people who are always subject to being put in solitary, it's just horrid.
Yeah.
Peter,
Yeah.
do you take up anything in this discussion? And then I'm going to go on to the next speaker.
I think the issue of loneliness was, as people outlined, so highly compounded by COVID because, you know, it affected everyone in the regular community. But if you think about the incarcerated population, it's just doubly worse, if you can imagine, because people couldn't get in touch with from the outside in. There wasn't a lot of information coming in, particularly in the setting of an outbreak, which is politically fraught. So you have lockdown from a disease perspective, but you also have lockdown from an information and security perspective. So it's, and then you have COVID, which in essence is defined by, you know, distance and being apart from others. So it's almost like the triple threat when in a setting of an outbreak that's politically charged.
You know, all of the medical and psychiatric people are saying or echoing what you just said, yet they don't have control. So the first thing the Department of Corrections and Rehabilitation did was to shut off visiting during the COVID crisis. And I agree with you, it's the worst move they could have made. And a lot of people suffered because of it. I am going to invite Dr. Mariposa McCall to join us on the panel. Mariposa, if you could say a few words, maybe 5 minutes, and then join us for the ongoing discussion, that would be terrific. Dr. McCall has a lot of correctional experience. She also has social and has a lot of important stuff to say about what we need to change.
Today, you need to make an appointment with online.
We can't hear you, Mariposa. Are you might be muted.
Oh,
Oh, there we are. Hi, Mariposa.
can you hear me?
Yes.
Yeah.
Oh, okay. I'm sorry. Hi, good morning, everybody. Thank you for hosting this so important discussion for our brothers and sisters and for us too, because what harm we bring upon them, we really do harm ourselves in many different ways at many different levels. And I worked at San Quentin as a contractor for 1 year, 2010 to 2011, and then the realignment happened, and several people, they had to reduce the population size there due to the court order, and all the contractors were let go. I enjoyed working there, working with the inmates, the people. There's so many words that it's trot the vocabulary. Inmates, felons, they're humans, and my experience working with them was very transformative for me. I had never worked in a correctional setting before. During my residency, I was completely unaware of this, and I felt so unprepared for what I was gonna encounter there. But having had that experience, it really, and I'll just say from the get-go that there's myths about, and I bought into it, about who is behind bars and who is hidden away from us. And having worked at that point in the community psychiatry for a number of years, working with victims and trauma patients, I thought, I don't know if I can work with the perpetrators. I don't know if I can do that. And I reluctantly accepted that job, but it was it was one of the best experiences that I have as a human being, not even as a psychiatrist, but because it really taught me that we are so alike in so many different ways. And who I saw before me, kind of a reflection of me, my life could have easily gone their way. And that fine line is we just need to reach out and really understand that you and I are not very different, and we need to be open to our humanity and really be vulnerable to accepting that, we can make decisions because of circumstances that we find ourselves in, and easily find ourselves in their shoes, easily, especially as a minority person, African Americans. We know that certain populations get targeted in our community and end up disproportionately policed in the community, arrested, and sent away. So that experience was so transformative for me, and I cannot thank all the people that I worked with enough, because they gave me such a gift to this day. I'm very, very grateful. And Patricia, I'm so sorry that our systems have harmed you in so many different ways. And I'm happy that, like you, that I'm grateful to Governor Newsom for letting you out of this horrible system. And there are so many people like you said, behind those bars. I've seen them, I've worked with them. I often sat before the men and thought, God, this person could do just as well out in the community. Why are they still here? They've served 20, 30 years, enough punishment. Their care can be managed. And a lot of the people that I worked with that developed some confidence in me and trust. If you listen to their history, their stories, they have so much trauma and so much like substance issues. There's so much things that we could deal with that in the community in a much more humane and safe manner than re-traumatizing them behind bars, in sending them to solitary confinement, which is torturous. And I've seen the stories. Once they leave solitary confinement, the damage, the lingering damage that has been done to these individuals, the fight that they have to put to just protect their sanity. It's just amazing, but we should not be putting people through that ordeal. I don't care what they did. That's not rehabilitative. It is not humane. And we need to do better, and we can do better. So I am going back to Patricia. I understand that we have harmed you a whole lot, and I hope that we as individuals can continue to raise awareness to what we did to you and to others. And I just want to apologize for our lack of action as a collective. And I hope that we continue to have these very important discussions and raise awareness to our leaders. And one thing that I found very difficult working in the system was advocating for my patients and trying to do right by them. First, do no harm. That supervisors, clinical supervisors, often cut corners, maybe because they're understaffed, but regardless, it's the patient always has to come first. We can never forget that. If we are going to be doing harm in some way, we need to step up and speak out and say, no, this is not good for the patient care. It's not going to contribute to how we as a profession relate to people. Because how are they going to trust us in their time of need? If they see us that we're in cahoots with the custodial office and we are enforcement and not therapeutic, they're not going to trust us. And trust is the essential ingredient for any human connection, not just the therapeutic patient-doctor relationship. But if they don't see you as a trusting source, suicide will continue. Suicidal behavior will continue. Violence will continue because they feel they have no one. And speaking of isolation, loneliness, and belonging, if you don't belong, if it is that we have nothing to lose, then people will do drastic things, desperate measures to be seen, just to exist. And it's a dangerous formula. Yeah, that's all I have to say. Thank you.
I don't believe you. You always have very smart, wise things to say. So, but if we drafted you to give this talk, would you mind staying and being part of the panel now as we discuss other questions?
Oh, no, yes, that's fine. Thank you.
Keep the video on. We need more questions from the audience. I have a few which I will read. I have one more question just among the panelists, and that is the vaccine. The CDCR is saying that 50% of people in the prisons are vaccinated. Does that change our discussion? Does that make the problems go away?
I can take that. Of course it doesn't, because they're vaccinated against, first of all, this COVID. We don't know if there's going to be a future variant that will come that will be vaccine resistant, that we created, because COVID is raging all over the world, and every time you have transmission, every 2 weeks you have a new variant being created. So that's one thing. And then most realistically, it's not about COVID, it's about the future pandemics that one can almost always worry about even more. That's definitely coming. So I think the vaccination against COVID wouldn't help against these future pandemics.
Joe, anything further about that?
No, but I did want to say, in sort of piggybacking to what Mariposa was saying, that the function of medical and mental health staff in facilities, I think, almost more importantly than providing healthcare, mental health care, is really, to me, how you interact with the patients. And one thing I always stressed with my staff in San Francisco was that, people who are incarcerated, really have nothing. They're locked up. They don't have much contact. They're not treated well. They're not listened to. They're not heard. And that the thing we can do is really treat people as human beings, as you said, and make sure that, even in the small setting of medical care, that at least they feel that they're being listened to and that their problems are being addressed. One of the things that's always a criticism is that, prisoners are complaining about everything and they embellish their symptoms and blah, blah, blah. And, the reality is the reason they do that is because people don't listen to them. So unless they make it sound like they're going to die tomorrow, they're not going to get medical care in a lot of places. And I think that the medical staff, because of the nature of what we do, is uniquely positioned. We're not concerned with security. We are concerned on some level, but that's not our main function. And we can really make an effort to treat people more humanely and set a model for the correctional staff also.
I want to mention something that's opposite of what you said, but it underlines the point you're making. With the COVID crisis, the solution to what the treatment plan with people who are COVID positive or have symptoms of coronavirus illness is to put them in the adjustment center, which is the most notorious security housing unit in the country. So what that does is it prevents prisoners from telling medical about what's wrong. They don't want to tell them that they're coughing or have a fever because the punishment for being ill is solitary confinement.
Right.
I want to read a message, a question from an audience member and get your feedback. I love that message that all of us can be experts. All of us can advocate. What 1 or 2 steps can we all take after this conference to be advocates for vulnerable populations who are experiencing incarceration?
Yeah, so I can start with that. I mean, I think in my role, you know, I'm not a card carrying activist or like a loud person who lies in front of doors and goes on hunger strikes. I'm kind of like a regular guy doing my regular work. And to me, the way in which I found it effective is that whenever I talk to somebody about something else in COVID, it might be like something they want to hear, like how you got COVID or tell me about these new drugs. I'll always slip in something about, well, we have to make sure everyone has access to this. And then maybe I'll bring in something about San Quentin or something like that. So maybe you assess the readiness, but I think you can be activists in everything that you do. And you don't have to be a loud activist. You can be a quiet activist and just sort of like shape the conversation. Or if you meet with your representative or your mayor, you just slip something in as well. And I think that was the way I kind of navigated around it. And then in terms of experts, I think infectious disease, we always traditionally think about the super sub expert about something or the other. But I think what COVID taught us is that we're all experts as long as you're scientifically based and you understand the science. There's so much to do for everybody because there's so much mixed messaging. And if you just waited for the quote unquote experts, nobody would hear anything. Or, I mean, plus data has shown that the most effective way of teaching is from peers. So I think like if you have community members talk to community members about vaccine side effects or so on, that is much more effective than the sage on stage. Those are some of my thoughts about that.
Thank you.
Yeah, for me, I think I think everybody serves a purpose, and in our own roles, in our own space, in our own areas of expertise. If we, kind of begin to demystify this idea of who is a prisoner or who is incarcerated and their worthiness. I mean, to humanize them after they've been dehumanized in such a way. I think talking about who they are and how they affect us and how they are part of us is an important way. Like for me as a psychiatrist in the community, that's something that is always in the forefront when I speak to my patients, when I inquire about their legal history or their family, is to open that door, this hidden door of incarceration or immigration or detention centers, and have space to talk about that and the fears that they may have about having loved ones inside during this just so threatening time in our, with the pandemic. It's good to have space. So to speak of that is important, and also share with your colleagues about what, who they are, the people that are behind bars, because they're going to be 95% of people that are incarcerated, they come out. Okay, and we need to support their reintegration and their, so that they don't return to those harmful structures.
Wanted to jump in with a quick announcement that one of our panelists is going to have to leave just a little early. So I just want, Dr. Chin Hong, I just want to give you a chance to, any final thoughts. Thank you so much for joining us.
Yeah, thank you. And sorry, I have to leave early. It was unexpected. But my last thought is, I think I love the last question. That's true to my soul. Is that there's another silver lining when I went to San Quentin last week was that the incarcerated individuals had formed these communities. So like the media unit greeted us, and it was so delightful, and I just loved it. And for those who don't know, they have a podcast that has gotten a lot of acclaim. It's called Air Hustle, and it won awards and everything like that. So if you haven't heard Air Hustle, that's my last pearl for the group. And that is really getting at community and trying to combat loneliness. So thanks so much for your
beautiful program.
It was great having you on the panel.
Thank you.
Another question from the audience. Patricia, thank you for your powerful, tragic experience. Can you tell us what it felt like upon release and what you did?
Okay, yeah. How was it upon release, when I walked through those gates? Like I said, I was pretty sore because I took a little licking, but I kept on ticking. But when I walked through those gates, when I saw the family, my children, grandchildren, I have some of them I couldn't identify because they were my children. My sons had gray hair that I couldn't see. I noticed them, they had gray beards and that I can barely see. I could not look at them until I got really up close. And I saw all these people that I said, oh my gosh, these are my loved ones. And when I saw all this love around me, prison was behind me. I started it was so much love surrounded me. I was ecstatic. You know, you start forgetting, like in the Bible, when the Torah said, forgetting those things behind and pressing toward the future. And that's what I did. That's what I did. I always dreamed for years of, I used to watch the Jack in the Box commercial, and that's where I wanted to go. But that's what I thought of was Jack in the Box, and all of my children and grandchildren were there in the parking lot waiting for me. And CCWP was there, and I got a chance to give them all hugs. And it was like heaven on earth. It was like heaven on earth. I've never experienced anything like that in decades. It was a dream come true. It was a dream come true. Yes.
Welcome home, Patricia.
Thank
it's
you.
so beautiful to see your smile.
Yes.
And
yes.
your eyes light up.
Yes.
That's love. That's love.
Yes. It was nothing. God's answered prayer. I prayed I call it the King Hezekiah prayer. I just told God to just let me live. Just let me live. Don't let me die in prison. And I call myself Queen Hezekiah, because King Hezekiah prayed, but I call myself Queen Hezekiah. Don't let me die.
Adjust your crown. Yes.
Yes.
Patricia, you speak softly, but you have such a powerful message.
Yes, and I pray. Yes.
Well, hold on one second. I have another question. Let me get to it.
Yes, it was the most joyful day of my life. Yes.
Hold on a second.
Yeah, it was no pain. I had I had
What do you
chemo.
think it will take for more medical or mental health providers in prisons or healthcare associations outside of prison to speak out about abuse and corruption within prisons, including by healthcare providers?
To get women, elderly women, there's so many sick elderly women there. These women are dying there. They can't, I don't know what, I mean, OPHU, these women are barely walking around and they're in their walkers, wheelchairs. They have no voice. It's just that there wasn't a day that went by that I just printed up letters, kept writing Governor Galvin Newsom, just sending them out, the same letters. My daughters, we kept persistence, perseverance. You can't give up. You can't give up. I told them, don't give up. They're so sick there. These women are so sick. Cancer, breast cancer. I told them they can't give up.
Mhm.
So Terry, in terms of the question you asked,
They just can't give up. They're so sick there, the women. These are elder, the women much older than myself. They
Right.
just can't give up.
You're absolutely right, Patricia. Joe, what were you going to say?
I was going to say in response to the question you asked, the person asked, I think it's very difficult. I forget who it was. It might have been you, Terry, who mentioned how difficult it is when you're working in a facility and you're dependent on the custody staff for your safety and security, to then criticize them or come out against them. I think, there's two things. One is systems, like I was saying, where the health provider is independent of the custody, where they're working for a health department. You have a lot more autonomy and latitude to do things like that because, again, you're reporting up through a healthcare structure rather than the custody chain of command. But even there, it's difficult because I know that some of my staff in San Francisco, if they saw something happening and reported it in terms of abuse by a deputy to a prisoner, that their safety was definitely in jeopardy. I mean, they were made well aware by other staff, custody staff, that they better watch out. The good news is, when I started working in corrections, the number of healthcare professionals who were working in facilities who were progressive, who really cared about the patients was really pretty small. I often wondered, why would someone become a doctor or a nurse and then choose to work with patients who they don't like and who they don't feel deserve medical care? And that was pretty rampant, I have to say, in a lot of the facilities that I visited. And over the last number of years, that's really changed. And a lot of residencies are starting to get their residents and interns involved in correctional medicine as part of their programs. A lot of more progressive young doctors and nurses are choosing corrections as a venue to practice because they see the need. So I think in terms of who the staff is who are in the facilities, while there's a lot of room for improvement, there has been a sea change, and a lot of good people who really care about the patients and want to provide high quality care are starting to work in those facilities.
Yes, sir, I had good doctors, Dr. Trung, Dr. Taylor, the chief of medical. I had good doctors. I have no complaint. In fact, I'm just finishing up my book, Battling Breast Cancer Behind Bars. I had the best of medical in prison. If it wasn't for medical, I think I would have been long dead. I had good doctors at CCWP and CIW. Medical was fine. Mental health was not so good. My medical doctors were good. It was the staff is what I had problems with.
So Terry, that raises an interesting question that I have, which is, when Patricia's talking about the mental health staff not being as good as the medical staff, that's something, unfortunately, I've seen in a lot of places where even if the medical care is adequate, there are significant problems with the mental health care. And I was wondering if you have thoughts about why that is and how to fix that.
Well, I'll also call on Mariposa to answer that. Mariposa and I are in an association, the American Association of Community Psychiatrists, where we occasionally talk about these kind of subjects. I think there's a very unfortunate selective process going on, and that is mental health practitioners who are really caring and want an authentic relationship with their patients find themselves stymied, usually because of the security situation. For instance, having to talk to people through a cell door instead of having a private confidential meeting. And when they complain about it, they get in trouble with the custody staff. This causes them to leave. So this is not true in every single case. And Joe, you spent a career in the San Francisco jail, so you somehow overcame this problem. But a lot of the best people leave because it's so limiting. Your clinical intervention is interfered with by security measures. The custody staff doesn't have respect for real mental health care, where you have authentic relationships with people and pursue their needs and desires. So the best people leave, and that's a very unfortunate selective process.
Yeah, for me, my experience when I raised concerns about various things that I was being ordered to do by my supervisor that I felt were, one, unethical, one, increased my professional liability, and then lastly, the increased bad outcomes for my patients. When I raised concerns in our staff meetings, or even individually with my colleagues, I would, more individually with my colleagues, I would get support individually. Then when I would raise it in the meeting, my colleagues would be silent. So I think there's numbers, there's power in numbers, but there's such fear among the staff about getting written up that they hold back, and everybody has their own reasons why they don't speak up. Maybe they have debts, they have children, they have a house to pay. There's so many reasons, and I had a hard time kind of just accepting that to some degree. And I felt in a certain way abandoned by my colleagues because I was getting personal support on the side. But then when it really mattered, when we had to kind of, tell our concerns to our supervisor, there was silence. So I obviously, I continued to raise my concerns and declined to do certain things. And I was written up for it. And never in my 20 years, because I worked at Pelican Bay this last time, and I had never in my 20 years of clinical practice ever been written up. And the reason was because I was refusing to write orders for patients in the highest risk level of care, which is the inpatient. Write orders, discharge orders for patients I had never laid eyes on, never evaluated. I said, I can't do that. That's not safe for the patient, and it's a risk for my license. I worked really hard to get my license. I have debt from my medical school still. I'm not going to put my license on the line or my patients' lives on the line. Once you write your name on someone's chart, you are legally bound to them. And I couldn't do that. And of course, that was not good. I got written up. That was so uncalled for, I felt. Nonetheless, I did see the patients, but I refused to do it in the manner that the supervisor was asking me. Just write the orders. No, I said, no, I will see them in a safe manner and do the orders in the correct manner. But I was written up even though I ended up doing the work. Put it in my file, filed all sorts of grievances. None of them, it was unjust, they declined. So the grievance process needs to really be worked on. People who complain about problems in the system, that grievance problems, like the way that it's being done, is a sham, it's BS. And there needs to be whistleblower protection. I mean, real whistleblower protection. And the union, the doctors union, needs to be there to support quality care. Because when I went to the union, it was don't start a war with CDCR. That's
Thank you.
yes.
Thank you, Mary. Those are great responses to the questions. Thank you for joining us, by the way. Thank you to everybody. It's time to wrap up. I really enjoyed this panel, and I think it's been a rich discussion. And I'll turn it back to you, Epi.
Yeah, thanks everyone for joining us, especially our
Yeah.
panelists and Mariposa for jumping on and joining the panel. I just want to remind everyone to join us for our third and final webinar. It's going to be Saturday, June 12th, provisionally titled "From Toxic Infrastructure to What Infrastructure?" And we'll talk about some of the reforms going on right now and more opportunities to change the system in some of the ways you talked about today. So thank you all. And we'll see you then.
Okay, thank
Happy
you.
Mother's Day, Patricia. I'm glad you're home to enjoy it.
Okay, happy Mother's Day to you all
Thank
too.
you.
Thank you.
Bye-bye.
Bye-bye.
Bye-bye.